Welcome back to another PCBH Corner. David and
Bridget.
We're really excited about this. Well, and I'm really excited because tomorrow, actually, we get to shoot a corner with Stephen Hayes. So really pumped about that to see how that goes and to hear his thoughts about all things related to the process-based kind of act and maybe even a single session approach. And I'm just really excited to pick his brain. But for today, what I was hoping to ask, I had an interesting conversation with someone, and we always, whenever we talk with people, we always ask like, hey, any PCBH Corner topics, anything that would be helpful for your team, anything. And the one thing that the individual I was talking to said was, hey, should directors see patients while being directors of programs? And I was like, oh man,
yeah,
and very clearly, this individual I was talking to, they're a director, and I was like, oh, I'm wondering what they're gonna say, right? Because you can almost see both sides of the conversation here, and probably both. I think almost given the preface before, we know everybody's doing the best they can. There's only so much time in a day. There's demands of just different things. So we don't want it to be something that it's like, oh, this is the right way, and because that would be a decontextual.
I was going to say, as we always talk about a contextual approach, I don't know if we can just straight up answer like yes or no. Or...
Right. Well, and every single question we get asked is always like, maybe. Right?
Yeah. Depends on the context.
Which, again, is a contextual approach. So where does your mind go initially with that question? One, even maybe think about like, where does the question come from? Why is that question asked? And how have you approached this? I mean, where's your mind go just initially about like, should directors see patients?
Yeah, I mean, it's a huge topic if you actually kind of start breaking it down, because you have to look at each organization. Is the organization brand new? So say, for example, the PCBH program or integrated care program is new. I would imagine in those situations that your team isn't built up, and in order for things to be financially viable, there's financially viable, but then there's also just operationally and clinically viable. So if you're a working director and you're doing that work, you're able to better be a role model. There's the whole saying that as a leader, like, don't ask anybody on your team to do something that you're not willing to do. So you're able to model, and then you're fully aware of the operational and clinical challenges inherent. So yeah, I think especially for newer programs, it makes a ton of sense for directors to be in the role at least a big chunk of the time.
Yeah, oh man, my mind goes so many different places. And I really love that you did say like, hey, at a new program, which there's an irony there too, right? Because a new program, there's probably gonna be a lot to kind of build up. There's gonna be a lot to do. And there is a sense, I mean, my mind couldn't agree more, that being in the clinic, being where, like, that's probably going to be the biggest, almost like return on investment, is being able to see what it's like, to be able to problem solve. As you're building a program and you're building almost like a puzzle, if you can't see what the puzzle is supposed to look like, the puzzle is going to not probably turn out the way you want to. And one of the ways to see what the puzzle is supposed to look like is that you're in it. You're in the clinic. So I am really glad that you said it that way. I think that's a really interesting thing. And
I was going to say, what's the other?
I continue to go back to what you said about, and we try to do this as well. Don't ever ask someone to do something that you wouldn't do. And similar, like, we don't know what we want to ask someone to do for not doing it. Like, we wouldn't, like, I'm trying to think of our handoff conversation that we always talk about. We always talk about like, hey, and we just had this conversation with the team, that, you're going to run, if a 2:00 patient checks in and a 2:00 handoff checks in or comes out, you take the handoff and you're late for the 2. But like, what if we never did that? What if we were just the person being like, hey, just be late for the handoff, but we never, or be late for the schedule, but we never had done that. One, I don't know if we would tell people to do that. Two, I think that would be, if I was a member of that team, being like, this person's telling me to be late for 2 p.m., but they're not even in clinic, or they never do that. Yeah, where's your mind go?
Yeah, I think that, that's why you and I stay in clinic.
It is.
A huge
and so
reason.
We are in clinic. We are in clinic. about 30 to 40% of our time.
Yeah, and we did another PCBH Corner on the lifeblood.
I was thinking that too.
Of PCBH work, and we basically sat here, I think at this exact table,
We did.
and said that that's what gives us the motivation to do this work, because when you're so intimately connected to what it means to get a warm handoff, what it means to fit in a patient, what it means to have a longitudinal relationship with a patient, then I just kind of got like chills just thinking about, you understand, why are we working so hard? Why are we having the conversations that we're having? Why are we looking at the metrics that we're having? Why are we building up the program and adding more BHCs? Because think about it, the more BHCs we add, the harder our job gets.
Correct.
It's not like you
No doubt.
necessarily like get compensated more.
Yeah,
It's just our job gets a lot harder because we're still doing clinical, and then instead of supervising back in the day 3, 4, 5 people, now that we're at 10. But if we weren't in clinic, then we would be so far removed from why we're doing it. Now, that's not to say that other people haven't figured out different mechanisms. This is just our reality.
Well, and sorry for cutting you off. I think it's a really good point, because the other thing, and we've talked to, it was Jeff that we talked to about this, about how he's always tried to have his job keep him clinical in any domain, whether it be seeing patients directly or if it's like shadowing people regularly, so that's another way that
that's a good point.
Like, if the team is growing and it's like, we need to make sure that all these different things are happening, we have, quality and stuff. Maybe it's more that individual's not in clinic, but they're still shadowing BHCs in clinic to maybe give them feedback or just know what's going on clinic-wise. That's another way of doing it. It doesn't have to be like a direct patient-facing, but some way, keeping a finger on the pulse of what it's like to be a BHC.
That's exactly what I was thinking, because you might be in say maybe a chief behavioral health officer role, and depending on how your organizational structure is, it might not be feasible anymore to see patients. But how can, like you're saying, as I mansplain this to you, but yeah, how can you keep the finger on the pulse of the situation? Now, we say that. I would say that if your team is what we mostly run into, where maybe you have anywhere from 2 to probably 10 direct reports, I don't know if I want to say it, I think you should figure out how to be in clinic as much as possible.
I could not agree more. Do you still remember, I know we talked about, I think it was the Lifeblood one, when we were at CFHA, it was our first CFHA, Tina Runyon, I think Patty was up there, I forget who else was up there.
Okay.
And they said it was like it was like new members or whatever, like early career. It was early career workshop. And they said, stay clinical as long as you can. And I still remember that, man. I was like, man, that's easy for them to say. Like, I get it now, where it's like, stay clinical as long as you can. And even more, I would say, not even as an early career, I would say as a director, stay clinical as long as you can. Yeah, I think that's a big thing.
And that's not criticizing.
No.
Again, like we said in the very beginning, every single thing is contextual.
Yeah.
So if folks have different parts of their jobs and breakdowns, and if something truly isn't feasible, then it truly isn't feasible. And if you look at a lot of the medical leaders, even CMOs in many situations, a lot of them still will do a day of clinic, or at the very least a half day of clinic, just something to stay clinical. And so I think that advice stands. And if you're a newer program, you're going to need we talked about the lifeblood, we talked about the vision. You're going to need the revenue, most likely.
Yeah, it's a way of
in the beginning.
It accomplishes multiple things. It seems like. I mean, do you remember? So when we were at the recent conference that we were presenting at, I was talking to one of the CMOs, and I was asking him. I was like, "How much are you in clinic?" And the amount that he was in clinic was like, "Oh my God, how do you get all this stuff?" Now his thing was, almost like you, it's like it connected him to his why very much, and he felt like he was more informed, because when someone talked about a workflow thing, or someone talked about, it's like, I actually know what this feels like, I know what that's like. When we talk about, well, just get your documentation done, he's like, I know what it feels like to have a bunch of charts.
So this is a really good point, because it's informing his leadership, because there's a flip side. If you are only seeing patients and you're caught in the whirlwind, as 4 disciplines of execution, 4DX, we'll talk about, if you're stuck in the whirlwind as a leader, as a working leader, And you never are able to take time to stop and think about, hey, how am I investing in my employees? How am I going to make this happen? What vision am I casting? If you're not able to do some of those core leadership things because you're only seeing patients and you're only in the whirlwind, there's risk to that too. So it's, and not saying that we figured out exactly, I'd say it's like, it's like anything. You're driving in a direction, but you can't just stay wherever you are.
You're always going to be, what would it be, course correcting.
You're constantly course correcting, and so you might get in a situation where you're doing too much out of the clinic. You're getting disconnected from the work, and then you might have a situation where you're seeing so many patients that you can't even think, and you stop and think about your team, and you're like, I have no idea what my team's doing, because all I've been doing is been not stuck, but focused on clinical work.
We know that life. We get into that a lot by being the 30-40% clinical. You know what's interesting? I loved what you were saying too, because it also made me think about how do we always describe when people are working with patients access via the E part of it, the external context. What do we always say is a good way of thinking about the external context?
Can we picture a day in their life?
Can we picture a day in their life? And that goes for, a director and leadership. Can you picture a day in your life of your PhD? And again, like we said, that could be you yourself seeing patients or shadowing regularly, just being in the mix. And as you said, trying to balance as much as possible. You also need to be able to know the different fires that are going on, the different things that you do need to focus on as an administrator or director.
I love that piece for the contextual leadership.
Yeah.
We should make sure that we remember
Put
this.
That in there.
Thank goodness we have it being recorded, because and I know we've said it in different contexts, but it's really pithy of as a director, who does contextual leadership, if you can't picture a day in the life of your direct report, if you can't imagine the stones in their shoes, or the things that make them feel connected to their work, if you don't have an idea of that, you're literally going to be driving without being able to see.
Two final things on my end that I want to say. One is going to be super controversial, so I'll let that run at the end.
We're at 12 minutes?
Yeah, we're good. We'll finish this up in by 20 minutes. The one is especially if someone's coming in as a leader and they have never done the work before.
Oh.
So if you're maybe coming from traditional mental health, but hey, you were maybe high up in traditional mental health and you're being brought in to either start a PCBH program or to oversee a PCBH program, that is a situation that I would say almost, we don't like talking in absolutes, but almost uncompromisingly, you need to do the job for a little bit.
I would think so.
I would think so too. So maybe this could be a suggestion for, again, if people are out there that, they took this leadership role because, again, they're a good leader, and that's going to be the controversial thing that I'm going to say next, but that you're a good leader, you're able to run programs. It's that would be a powerful thing to make sure, because the interesting thing is, as we've talked about in so many PCBH corners, there's so much that goes into PCBH. If you don't understand the nuances, the nitty-gritty, there's going to be so many questions that you're just going to be I have no idea. So being able to live that through experience, not just reading about it or coming to one of our trainings or something like that, living that experience would be a powerful thing for the team.
Yeah, when you were talking and I was listening, I wrote down
She's never listening.
clinically and operationally, which was to your point. That of living that. Living the challenges clinically and the scenarios. I mean, there's scenarios. So we've been doing PCBH for 11 years, full 11 years, right? We did some integration before. I don't know if I don't know what I consider it, but 100% all in, fully integrated primary care behavioral health for 11 years. And sometimes to this day, when I'm working with my supervisee, they're bringing up scenarios that I've never even been in.
Yeah.
I've never even experienced. That's how many nuances, that's how many things I wrote, too many stones in the shoes. There are so many different scenarios of what if this happens and that happens and this thing happened? And if you don't even have a basic structure in your mind of hitting the high notes of the most common ones, and then if you have those, then you can at least extrapolate a little bit into okay, well, it was 2:05 and the warm handoff came in at 2 and my 2 o'clock patient was there, and to be able to go through. If you haven't lived it, I think it's a really tough proposition now. I think that we should never say an absolute because we're not in that situation. But if it was my advice which if you're watching the PCBH Corner, maybe you're watching because you're hoping for our advice. I would think it would be a very, very good idea to figure out how you're going to practice at least a little bit. And that's fantastic if the person was a really good leader in a different context, because that tells me that they probably have really sound leadership principles, and those should translate. Principles should translate. Practice is a whole other beast.
Now my mind's saying I shouldn't say the controversial thing, because that was just really well said. I think that was a good way of ending it. But I will say this. I'd love to know what your thoughts are.
How is there another controversial thing?
I didn't think that was that controversial. Was that one that controversial?
I don't know. It could be.
Well, I don't know. Here we go. We're here, right? Let's just do it. So the one thing I've always struggled with is this notion of like, I have a different skill set to be a good leader that doesn't allow me to be like doing the clinical work just doesn't drive me. That just doesn't motivate me. I would just be very, very cautious with that language. I think when there's a sense of this idea that's like, hey, these are different things. There's clinical work and there's leadership. There are definitely different skill sets in different things that I think could go along with that. I just struggle with the notion, if there's something, again, I want to know where your mind goes with this. And the reason why I struggle with this is because obviously it goes against what my view, so I have no data on this. And I know there's a lot of different things, like the whole thing about like, usually the people get promoted are the good at one job, so they just get promoted, but it's a completely different job. And I do believe that. Again, I do believe there's different skill sets. Right. There's different skill sets. I just struggle if someone is kind of like, yeah, clinical work just doesn't, do it for me. It's really like all the leadership stuff, the director stuff. Not saying that can't work. My mind just goes, I think we should probably be really curious about what's getting in the way of the clinical work driving you.
I mean, I think that there's common sayings that some of the best leaders some of the folks who should be in leadership are the ones who want leadership the least.
I know.
I do think that I know. We got landmines everywhere.
I tell you, I was, even as I was talking, I was like, not that one.
Yeah, we got landmines everywhere. Yeah. So I think that it maybe goes back to the positions of power. So the folks that are pursuing power probably are going to be the most ill-suited for a leadership role.
Well said.
The folks that are deeply entrenched in some type of mission, those folks are going to probably be the most best suited for leadership. So going back to what you're saying about the clinical role, and this is where I guess I'm going to talk out of two sides of my mouth. I think that if somebody is all in on whatever mission that clinical work is achieving, so for example, healthier communities. So say you're a person and you're 100% on how can we have the healthiest communities possible. And say it's not your most favorite thing that's ever happened, like in your list of what you'd rather do, clinical versus something else. Maybe you're a huge systems thinker. So you're constantly thinking of how can I get more folks into the door? I think we're fine there. I think you got to be careful of like not trying to get out of I'm going to go help a bunch of people, but I'm going to get out of clinical work. Like if that's where your brain is going, like that's not good.
Can I pause you real quick? Because that's something I wrote down. Make sure that you know where you're going, because I love how you've articulated this and you've done a good job of saying what I was trying to say in a very good way. The one thing that I just wrote down, it shouldn't be easy to give up clinical work. If it's easy to give up clinical work, like there's almost like, oh, this is easy to give up.
And by give up, you mean like not doing it anymore, right. Not going down from like 8 clinics down to 6 clinics.
I would also say that like each clinic going down or each percent, that should be met. If it's not something that kind of like there's some pause to or some discomfort to, I would pause on that. I'd be like, why? Because here's the thing. If the truth is, because clinical is really hard, that's almost something that it's like, I don't know if that's so instead you're saying that the team or the people that are in clinic, like I'm okay with them doing something that's really hard, but it just is really hard. Now, if it's getting in the way of, as you said, being able to focus on the system, to be able to work through some workflows or to be able to have meetings and stuff like that, like that's for sure. But that's the thing, I feel like if it's easy to give up a clinic or clinical time, I would pause on that.
Well, because then it could be a situation where, are you really back to being mission driven?
That's what exactly.
Are you really? Because it should pain you to a certain extent. But if you're able to see a different route of like, I know that if I can get this system running this way, so many more patients are going to be served and our community is going to be served. Versus, hey, doing clinical work is really hard. I want to try out something different.
Yes.
So I think that first one, the former, is like, so back to, is it cool to go back to what I was, So that mission driven, I think, is what's most important. And if you're in it like, I want to pursue leadership, that would be a situation where I would pause. If you're like, I have this really deeply entrenched mission.
And why and value.
And this mission is something that I want to get out there. How can I do that? Leadership, that's a route for me to do it. I think that's really good alignment. But if it's like, well, I want to be able to impact the system. I'm sorry. That alone, and I've said those things, so I'm like calling myself out. That kind of sounds like power.
Sounds like ego.
Yeah. It sounds like ego. Yeah. And, I would say in order to do leadership, to a certain extent, ego is going to creep in because you have to, you're flirting with that line there because you have to believe that you can make a difference. So inherent probably in being like, hey, I know a way, I know how we're going to make a difference. Ego for sure is going to creep into it. It just can't be the main thing, in my opinion.
This past 5 or so minutes, you've done such a good job, I think, of just articulating what I wanted to say.
I feel like we've talked about this offline.
Well, what's interesting.
Ways.
What's interesting too. I think I'm having a deja vu moment. I think there was a PCBH Corner we shot up in a small conference room back in the day about this topic, about just being like careful, like just pausing at times. I think that's the right word, of pausing. Doesn't mean something's right or wrong. It just means pausing and just checking in with yourself. What is causing me to do this? What is taking me out of clinic? Why is that the thing? Go ahead.
And I think that, that's something that we constantly ask ourselves.
Yeah.
In the role that we are in, where you're a trainer, you're a speaker, you get a lot of positive reinforcement from being a speaker. You get positive reinforcement for doing these corners. And so, I know that you and I are constantly like, hey, are we making a PCBH Corner?
Yeah.
So that, so that we can get attention? Or are we making this PCBH Corner because we truly think that this is pushing the field forward? And that's something that we have to think about and pausing. So it's not saying not to do PCBH Corners. It's not saying not to be a speaker. It's not saying not to be a leader. But you are in a situation where you might have a little bit more power or influence, and I think it's really important to stop and think about it.
If it was a time that you need to be grounded in that why and that value, which I will also say as we end, clinical allows, at least for me.
For me, it does too.
It grounds me in my why and my value all the freaking time.
We said in the Lifeblood PCBH Corner, whatever episode that was, I think it was in the 30s or something. And now we're in the 70s.
This is 80, I think.
Oh, this is 80. This is 80. Oh, yeah. All right. Yeah. I agree. It gives me the motivation to push when I don't feel like doing it anymore. Because when you're so grounded in that clinical work, it's like, why am I fighting for another position? This is why. Because if we get another BHC, this BHC, whoever we hire, could have this many moments with this many patients serving our community.
When I go to senior leadership and I talk about the impact, we have stories. We have not only stories we hear from we have our own stories to be able to share. And
it's that visceral grounding.
Yeah. Well said. Well said. And so, here's the thing. A gratitude for people giving ideas about PCBH Corners. We will do them. So please keep giving those to us as much as possible, those thoughts. And, the final consensus on this, as always, should PCBH directors and leaders be in clinic, context is going to depend on that. It just probably shouldn't be easy to come out of clinic. Make sure that it's still ways of grounding you. You're still involved. You can understand a BHC's day in the life of what they have to deal with. And just make sure it's connecting to the why and the value.
Yeah.
Well said.
And probably you should.
I would say the same thing. Stay clinical as long as possible. All right. Take care. And as always, thanks for stopping by.